Good evening, everyone. Can I please just get a response in the questions box if you can hear me? Just a quick yes, and I will start this webinar. Perfect. Can see some yeses coming through, so I'll get started now. We'd just like to say good evening and thank you all for joining us this evening for the New South Wales COVID-19 update webinar. My name is Beth and I am joined tonight by our panel from the RACGP and the New South Wales Ministry of Health. Welcome Dr. Charlotte Hespy, Dr. Penny Burns, Dr. Kerry Chant, Dr. Nigel Lyons and Professor Christine McCartney. Firstly, I would like to do an acknowledgement of country. We recognise the traditional custodians of the land and sea on which we live and work. We pay our respects to elders past and present. I will now pass you over to Kerry to provide the latest COVID-19 update. Thanks, Kerry.
Thank you very much. I'll keep this very brief, but suffice it to say that recently we've seen quite a low number of cases. We haven't had a case of recently acquired local transmission case since the 26th of May, but I do hesitate because we continue to see high rates of testing, and even though we've had that period where we haven't had a locally acquired or a recent locally acquired case, it's important to say that we aren't confident that we've totally eliminated COVID, and as we ease restrictions, we remain at risk of seeing increased interactions and therefore raising the reproductive rate of the virus and potentially seeing an increase in cases. So I do urge you to continue to test because having those high rates of testing is essential for us at this time when we're easing restrictions so that we can detect any community transmission at its earliest phase and block any further transmission in the community. Probably just a couple of other comments to make. Currently, we're also doing intensive case finding around any cases. So we did, for instance, have a case, but when we tested that case, it was serologically showing immunity, and that helped us identify that it was in fact an much older case. And so that's again what we talked about last time on the webinar, that serology can complement our diagnosis of cases to lead us to timing, determining when people were infected. We've also now, because we have so few cases going back the 14 days prior to the onset and really looking for that source case. And so the scope and extent of our investigation and case finding has expanded and will continue to do so as we're really trying to detect and hunt and stop any community transmission in the throughout in our response phase. So I just wanted to give you that sense that we have, albeit we've had a period of low transmission, we can't be complacent, and it is important that we still maintain those high levels of testing. And at that point, I'll hand over to you, Charlotte, to ask the questions.
Thanks so much, Kerry. Hopefully we've had a bit of technology issue tonight, everybody. The internet is not behaving, so which is why you can't see Kerry. So if you can't see anybody else, try and put yourself into the different view. It might be a sort of change around your Zoom so you can see better. So thank you, Kerry, for that warning. So I take that as saying that we just need to continue to be diligent and be aware that the more people come back in contact with each other, the higher the risk that the virus will re-emerge. Are there any other sort of salient lessons? I mean, we saw today the results in Melbourne that one of the marching people actually has been tested positive as well. Should be, as Sydney's got 2 marches planned, I believe, Friday and Saturday. Are there any sorts of things that we as GPs can do to help manage that more safely?
Clearly, the risk is associated with any mass gathering or large events, and that's why Australia's taken the approach of limiting large gatherings. What a large gathering does is it brings people into contact that potentially would not have contact in the ordinary course, and that allows those contacts to then potentially seed different social networks. And so when the virus might go through a couple of different phases of transmission, it really becomes very difficult to identify that you've got a single source outbreak, and and you can get the emergence of clusters spread more widely. And I think that's why we have had the approach of restricting large mass gatherings. Now, some jurisdictions are easing those restrictions. We're obviously in an easing phase, but we also are trying to maintain the principles as we ease of keeping groups of people as distant as possible. So what we're terming sort of COVID-safe behaviour. And clearly if someone is going to protest, we're not advising people with any symptoms to protest. We're clearly also saying that people at risk of infection, the elderly and the vulnerable, it's not a good idea to go into a mass gathering setting, be it a protest or any other mass gathering environment. And clearly, if you are in those environments, things like washing your hands, using masks if you are going to be in those close environments, and particularly not going into those environments if you have any symptoms, are sort of risk mitigation strategies.
Yeah,
I was just going to say, I think that there's some lessons there in America, coming from America at the moment, where they're discussing the sort of the potential second wave with sort of as the states are reopening, and they've got, Florida's reporting, 8,500 new coronavirus cases, which is the most they've ever had in a 7-day period, and Texas as well, and some of the other states. So I think, I think we do need to be very careful about how we go about the next phase.
There's some questions just sitting there in terms, and I think worth asking, because this is certainly really hot GP conversation, which is around the testing of children. It's really this sort of poignant thing of the kid who's just got really mild respiratory tract infection symptoms. Do we test them? Don't we test them? Can we just send them home to stay out of reach of anybody until they're no longer potentially infectious? And what time frame is that? The amount of debate I've been hearing, can I say, on those topics. I would love, Christine, Nigel, Kerry, anyone to add to that sort of conversation and where we're heading, because it's the GP, that's the big number of people that we're seeing right at the moment.
Look, at the moment, I'll just answer it from a public health perspective, and then I think Christine putting that clinical lens on it would be greatly appreciated. So I'm giving you the harder parts of the question. But from a public health perspective, we do want to see children tested. Whilst they're at lower risk of transmitting, they're an important sentinel population for us. And as I said, early detection in children is going to signal the fact that there may be parents involved or broader contacts in the community. And so it is essential, particularly at this time when we're easing restrictions, that we cannot lose control. We want the earliest possible warning, and we want to respond and break those chains of transmission. But Christine, do you want to talk about the clinical issues and what symptoms you look at?
Sure, yeah, thanks, Kerry, and hello, good evening, everyone. So I'm a paediatric infectious disease specialist, and I, see children once they hit the hospital, not in primary care, so I fully appreciate how many children with respiratory tract symptoms, infection symptoms you see. But I would echo what Kerry has said, that at this time it's just really important, I think, to have that willingness to test people of all ages. And we will, of course, as restrictions are being lifted, see respiratory viruses coming back. I mean, we've been at an all-time low with things like influenza for this time of the year, about 1/9 of the, influenza activity that we would normally see. So we will see RSV coming, we will be seeing rhinovirus, we'll be seeing influenza, but we could well be seeing COVID-19, and we cannot tell the difference. And echoing again the comments that Kerry made about children being sentinel. I mean, they're different. They're not sentinel chickens like the mine, or the sentinel canaries like the mine, in the sense that they actually are sick and dying from this disease, but they are catching the virus, particularly in households, we think, and in close contact settings. And that's often an indicator that there might be an adult who's infected, and that adult's getting about and going to work. And so I think test, test, test remains the mantra. And, you know, I guess, I don't know, you would know very much this as well, but I find as a clinician, it is sometimes fairly gratifying for you, as a clinician, and for families to say, look, actually, I can test you for about 15, 16 viruses, including COVID-19. I'm going to be able to give you a pretty good chance at finding out whether this is a virus that they've got and what that virus is called. And that's often quite, you know, helpful information for families as well.
Yeah, thanks, Christine. I think I know at our clinic we're seeing a lot of under fives, particularly coming in with really snotty noses, and sometimes we're seeing them with something else, and then the nose starts running right in front of us as we're treating them. I think we're sort of getting some questions around when we should be re-swabbing, and so when do we sort of you know, when is it a new condition? I know last 2 weeks ago we were talking about how you swab for one condition or one clinical case, and then if they get another bout of respiratory infections, then you would re-swab. But how long do you wait before you re-swab someone?
Oh, look, that's always a hard question. I think it does depend on the clinical history. So, I mean, if it seems to be that it's a contiguous same illness, and you know, they've just continued to have the runny nose, now they've got the cough, you know, they're a little bit lethargic, they're needing fluids, you know, now they've got a temperature, but it all seemed to start with the runny nose, and you swabbed at that stage. I don't think you need to retest them unless clinically they're really changing and you've got a concern about secondary bacterial infection. But yeah, look, you know, I think we will be in a situation where we'll be doing quite a few more swabs, particularly I'm hearing in primary care, for respiratory viruses that you wouldn't have tested for before. I don't think you need to test every 3 or 4 days. You know, if it's the same illness, we know it'll run its course over usually a week to 10 days. And you will pick up that rhinovirus again, or that RSV again. But if there's a clinical change, if there was a gap in the history, they seem to get better, now they're unwell again, they look different, clinically they're different, that's probably a time to test again.
So I'm hearing that we do just keep testing and do more than we have before. Try not to be persuaded by those around us to not test, and just continue to be diligent and sort of have a better understanding of what's actually happening around us. Which sort of moves us into that thing about masks too. Kerry, you mentioned masks for the social setting, but the GPs at the moment are wearing masks for seeing every patient. How long do we do that for? Or do we, after our screening, decrease some of our diligence? Certainly in my practice, we're not going to, but I've been hearing about some practices that have been changing that. I mean, we're doing a lot of telehealth still to avoid anybody coming in at all, but we're certainly wearing masks for seeing everybody despite that. What would be your take on that? And I'm happy to hear Christine's in terms of the paediatric one as well, and or Nigel if he's...
So Charlotte, I think the guidance, there's some updated guidance documents which is going to be put out, which again reflects the current thinking about the sorts of PPE that people need to be wearing. I think that COVID's actually challenged us to rethink our PPE. I think we probably weren't wearing as much PPE in both primary care and the hospital setting than we should have, commensurate with our understanding that there's flu about and other respiratory viruses. And so I think that we need to understand the risk of COVID is low, but what elements of our practice are appropriate for any respiratory virus, be it COVID or otherwise. So anyone presenting with those sort of respiratory symptoms, it is prudent to be treating it as for respiratory and droplet precautions. So I think we probably need to use this opportunity to reframe our infection control practices in general practice, just as I think it will reframe our approach in public hospital systems. Christine, did you want to add anything about?
Yeah, look, I'm with respect to the official or the updated guidance, I'm not sure that I've seen that, but I would say that, who of us who sees children, for example, and sick adults, patients, who hasn't come home sometime and said, oh, I think I might have got that at work, and so I think that does always reinforce to me that it's wise with someone who has a respiratory illness to be wearing a mask, and that's probably a good idea at these times. It's certainly not a bad idea. Per se, but it is a complicated matter. I think people just need to be thinking carefully about the patient that they're anticipating seeing at the time. I know that's not always obvious when they walk through the door and you don't know what they're coming in for either, but certainly having that willingness to wear a mask in close range care is important.
So one of the other comments that's coming in, so around the testing children, of course, is back to swabs. And we do cover this each time, but we've got some new questions about this. And I work in a respiratory clinic, and I know at our respiratory clinic, we're doing oropharyngeal, then one nose, then the other nose. So oronasopharyngeal testing. But this question says that they've heard that some of the respiratory clinics are doing cheek swabs for COVID PCR, and that there's evidence to support this. So is anyone able to comment on that?
Look, I think I provided guidance last webinar about the updated Public Health Laboratory Network guidance, and we're happy to circulate that. But that was, Penny, I think, consistent with the advice, with the practice you just described, which was the oropharyngeal sort of specimen, swabbing the throat, and then doing both nostrils, acknowledging, I think we had the discussion last time about once you have children, good luck to get the second nostril, but we did say to persevere and do the best you could.
Yeah. And one of the other questions coming up just after that, just while we're still on this, is that someone's asked, so after COVID testing the children, can they go back to school straight away? And I guess, I think we addressed this last time, but obviously they need to stay until they get a negative result. And if they've got any symptoms, then we should be staying at home anyway.
I think this is where we had that conversation about, actually, it's a bit like Kerry was saying, this is a good opportunity to actually re-look at our PPE for how we're actually doing that. It's also a good opportunity to review our advice about the standard cold. I think we've had a tendency to let people go into the workplace, school and preschool with sort of symptoms that do potentially spread it to others around them, and that maybe this is an opportunity for us to be a little bit more rigid and say, no, sorry, you actually do need to stay home until you're not quite as infectious. As when you're a parent of small children, that can be extraordinarily irritating, because you can sometimes feel like you're just lurching from one infection to the next, but that actually may be the benefit, that you don't have to go lurching from one to the next if there isn't so much infectious material hanging around the preschool. Maybe the children will actually be able to have less infections and spend more time at school well rather than sick. Christine, happy to take your...
Look, I mean, there's some silver linings to the clouds that we've been dealing with, aren't there? And I mean, I'll give you a silver lining. It's not, it's counterbalanced by some of the other real challenges with not having children go to school, or not having children, out and about in the community as much. But we have seen a real decline in the paediatric hospitals of hospitalizations for serious respiratory illness in various. So, I'm talking type babies and influenza type babies, all of these young babies who just aren't, we haven't seen it, it's just gone. I mean, you know, very, very few children with acute severe respiratory illness. And we know that that sort of illness, particularly early in life, you know, has been associated with a tendency for more reactive airway disease and potentially for longer term, you know, asthma. There's different evidence on that, for example. But, you know, it nonetheless has saved a lot of parents actually bringing their child to being admitted to the children's hospitals at this time because of the social distancing. So it does, I think, support the idea that swinging that pendulum back a little bit about keep you and your child home if unwell is a really good idea.
So, Christine, can I ask how the current sort of influenza vaccinations fit into that? Because we've been flooded by children and adults coming through to get their influenza vaccinations, and also the pneumococcal vaccinations as well. How is that impacting the COVID response, do you think?
Well, I think firstly, congratulations on delivering all of those vaccines. You know, we've seen a huge demand for influenza vaccine this year, and I think there's been a lot of messaging around that. The public have heard it. You know, the primary care is delivering those vaccines. So I think we're on target to have about 18 million doses of flu vaccine in Australia in a population of around 26 million. And obviously we have a fairly wide funding now with the bringing on board the free vaccine for children aged 6 months to 5 years, which was first done by the states and territories, New South Wales included, from 2018 onwards and through to 2019. And this year it's, you know, under the National Immunisation Program, flu vaccine for the young kids. We've got a pretty comprehensively, you know, at-risk flu vaccine program. And people are hearing that we've got more doses going into the register, which is critically important. So it's a plug to me to say all of you, you know, who just double check that all of your vaccines are getting uploaded to the register and that you're really confident that your, you know, your software is interacting with and uploading to the register, because that that register is now showing, you know, a big jump up in recorded doses administered as well. It's still not capturing all doses, and there's two aspects to that. One is that sometimes practices aren't connecting, you know, such with the air that the data is transmitting properly, but also we know some people who provide vaccines, including flu vaccine in particular, aren't yet linked up to the air at all. So by there I'm thinking of, you know, some of the workplace flu vaccination and dare I say it, hospital vaccination and others. But nonetheless, lots more flu vaccine being procured and distributed. I know there's been issues a bit with, you know, bumps in the road with supply, but, you know, there is a lot of vaccine that is still coming, is my understanding. Kerry might want to add to that. Really important to get the vaccine on board. Of course, it protects you about 50% of the time, but what a good, you know, odds that is in respect of other things we might do to prevent flu. And likewise with pneumococcal vaccine. And it's also a chance for me, I guess, to plug that we have a webinar next week, which is on the upcoming schedule changes, if people haven't heard about those yet. There are national immunisation.
They're very exciting, can I say, Christine? Very exciting. We as a practice looked at them just this week and went, wow, okay, bring it on. So.
Well, it's pretty complicated, but, you know, I'll stop there. But you know, I'm happy to talk about the webinar. But it's on. You can join up by going to our website, which is ncirs.org.au, and of course that's complementary to all the materials coming from New South Wales Health and from the Commonwealth.
Thanks, Christine. I'll just do a plug for GPs and say how I agree we've done a wonderful job with flu vax. I mean, just my own practice, a suburban practice, we have done double the amount that we would normally have done at this time of year, and it's just amazing. I mean, though I do find it interesting, you know, some of our target populations still aren't up to, we haven't done as many as I would like. So that probably says to me that we're vaccinating a lot of the population that have never had it before. But I need to then as a GP go and chase up all the people who may be avoiding the general practice still because of the fear of getting infection. So we've still got a body of work to do in terms of making sure all the people I really want vaccinated get vaccinated.
Christine, can I ask you another question? I don't know, and I don't know if you can answer this, so say if you can't, but are there any statistics, you brought up AIR, on the level of childhood immunisations, routine immunisations having dropped?
Yeah, so I'll give this one a go, and Kerry may want to add. So there certainly haven't, if you look on the Commonwealth website and the reported data, which is sort of aggregated in a rolling aggregate way, there is no drop. Now, I don't think it would be unreasonable to say, did you feel a drop in March and April? Were there fewer kids coming to be vaccinated? Yes, I think there was a little dip down, and we have been looking at that, but I don't think it's been a huge dip down, and I think it's what we would call a recoverable dip. So I think, was this a statement from, in fact, the college, or there've been one or two statements, obviously, about the importance of ensuring that routine immunisations are delivered. And I think a statement has gone out, which I know I contributed to, about any missed doses that may not have been, delivered during March and April, time to go and catch those up now. So I don't think we're going to get into trouble with immunisation coverage here. I think the main thing now is to encourage your patients, if say, the toddler missed his 12-month immunisations in April at the peak of the epidemic, to come on in now and get those. And that delay shouldn't necessarily be deleterious, but it is a really important message to be sending, particularly to children who have all of those scheduled doses. I don't know whether Kerry wants to add to that.
Kerry?
No, that's all right, Christine. I think you've covered it, and I think if there's any need for us to do some more social messaging or feedback, we'd be happy to pick that message up. So maybe Charlotte or Christine, you can let us know if you still think that that's your sentiment from GPs, that people aren't coming for vaccination.
I think we feel like people are coming, but we're actually about to do a data review to see what evidence there is about that, so I can come back to you. But we certainly, from a college perspective, have been very strongly doing the message about come and see your GP and get the routine care. So while I've got you, Kerry, there's a question that says on the New South Wales HEP website that you believe there's circulating virus in the community, and she's asking, what evidence is there about that, and is it fecal testing being done in the sewage that is making you know that there's community spread, or virus anyway?
So I suppose it's a combination of factors. That we know this virus is a very mild disease in many, and that on that basis, there's concerns. 2 weeks is a short time, so model data or estimates can show that you don't see a rapid upswing in cases, even in the presence of easing restrictions, for a period of 4 to 6 weeks, because you've got the incubation period for the disease being anything from a day to 14 days. So my comments about the fact that we can't be confident we don't have circulating virus is that, but I've also indicated that we're obviously aggressively testing, and we'll announce if we have any additional cases of community-acquired infection. I think it's a challenging time for us because we have diagnosed some cases that have been positive, and that they have been, when we've done serology, we've been able to ascertain there have been older cases, and that's one in relation to a case in a overseas traveller who's been here for quite a period of time. So I think it goes to the fact that the test, we can often pick up remnant parts of the virus for a long time in people. We've also had the issue of the challenges of false positives when you've got a low pre-test possibility. But for all of those cases, we still couldn't put our hand on the heart and say we don't have locally circulating virus. It's not in relation to sewage testing. At the moment, sewage testing would be confounded by actual cases we have. and so it would be hard to discern that. But I'm also going to get a briefing on the accuracy and the science of the testing. I know we're involved as a partner in that through Sydney Water and through the CSIRO. But again, I want to understand the limitations of that testing and what we can impute from it. And I know it has been employed in overseas in, research settings. So I think there's still more to learn about how to use sewage testing and what you can reasonably conclude from it. Christine, I don't know if you want to add any comments from CDNA's perspective.
Yeah, look, just on sewage testing, it's it's been used in many countries and intermittently in Australia, not extensively, for polio. So, we know we used to use OPV, oral polio vaccine. And of course, when we didn't do sewage testing then because the vaccine was pooped out into the, the sewage. But in a country now using all IPV, it's an option for us to say, are we getting any introductions of people shedding polio virus by looking at the sewage? So it definitely can have utility. And it has, as Kerry said, there's briefings and a paper circulating on this as a concept. But but I think it's got to be very carefully examined as to how you use that data for decision making. I mean, that's part of any surveillance, any screening, any testing we do. How do we interpret that data and turn it into whether public health advice, patient advice, whatever. So I think it's kind of early days still for the concept of screening through sewage, and that's going to be really interesting to see how that evolves. But I would just add on the virus. I mean, this is one sneaky heck of a virus, right? I mean, it is it's got the really nasty sting in the tail, the severe disease in a proportion of people. The mild disease in the vast majority of people, and then also asymptomatic infection. So it's just perfectly designed to be moving through the community with us having a real challenge in detecting it. And it is, as you loosen restrictions, you can't imagine that we're going to see less virus if there's any out there. You've got to imagine we're going to see it pop up, rear its ugly head here and there. And that's why it's so important to be maintaining vigilance, sticking with the stepwise, gradual lifting of measures that have so carefully been thought about.
And I guess that brings us to the vaccine. Is there any update, either Kerry or Christine, about the vaccine and what's happening there?
I'll defer to Christine on this.
Well, I guess I would say vaccines. So all of us who sit back on and read whatever we read would be aware now that there's not just a few candidates. And when I say candidates, I mean just coming out of the starting blocks. Last count, and there's a WHO tracker on this, there's a great London School of Hygiene Tropical Medicine tracker, there's around 130 candidates. So this is where, someone in a laboratory has got something exciting, they think it could be immunogenic, that it could ultimately form a vaccine, and they're taking it forward, and they might be starting to do animal studies. How many are in clinical trials? It's around a dozen now. So vaccine candidates in clinical trials, and you might have seen that the first vaccine candidate against COVID-19 has gone into, in Australia, to be in a clinical trial, has gone into a clinical trial that's enrolling patients through sites in Melbourne and in Brisbane. And that's a phase 1 study, so very small number of healthy adults. But across the world, we've moved into some phase 2 studies with some vaccine candidates now. The Oxford vaccine candidate, which is a really interesting one, and I'm happy to talk about how they're all made, but that might put you to sleep, but it is really fascinating. So the Oxford vaccine candidates, aiming to do at least 1,000 people in what's called a phase 1 and phase 2 trials. So expanding out to try and look at efficacy as well as immunogenicity and safety. We've got one of the vaccines out of China that has just reported the very first actual formal results, reported in a publication last week in the Lancet, showing that in a small number of people that vaccine appeared safe and immunogenic. And then we have just unprecedented partnerships and coming together of large groups to take a range of different candidates forward super fast into clinical trials. So some other phase vaccine candidates like the Moderna vaccine in the US now entering phase 2 trial and announcing that they may be ready to enter a phase 3 trial, the larger trial, which is typically many thousands of people, in around Q3 this year. So big developments, but so much more needs to happen, and before we can expect to see it, in our fridges, your fridges. There's a lot of other steps with respect to obviously ensuring many facets like safety, efficacy, but then simultaneously being able to produce a vaccine at scale, being able to ensure policymakers that it's suitable for use in certain groups, and then being able to distribute the vaccine and work out who are the priority populations for receipt.
Really interesting. I mean, I've been trying to see that. I was fascinated by the number of different styles of vaccines that were being developed too. And, sort of in terms of how you stimulate the immune response. And, as someone who hasn't really had to look at much of that since, well, for a very long time, it's like, wow, I didn't realize, that there were so many different ways of actually doing it for the same virus. But I suppose what's really even more exciting is that no one's ever managed to do it for a coronavirus before. So if this happens, then that's a huge breakthrough just for then all of the coronaviruses down the track. So it'll do a whole lot of vaccine programs positive work as well. That's my naive approach.
No, look, it's spot on. I mean, and I think it's come at a really unique time because we have seen, epidemics of new and emerging diseases almost every couple of years. I mean, when you think back, think how many viruses you've been aware of that have emerged just in the last decade. So, we saw SARS, we saw MERS, we've seen Ebola, re-emerge a number of times. We've seen Zika virus. We've seen a number of other really unusual, who'd heard of chikungunya, a decade or 15 years ago. We've seen a lot of viruses emerge, and simultaneously we've had this whole, molecular and incredible sort of scientific revolution. So now we're really seeing designer vaccines. We're seeing amazing technologies brought to bear, whereby you previously used to take a bacterium or a virus and you'd either completely kill it, inactivate it, or you'd take a bit of it and that'd be your inactivated bit, or you'd weaken it in a culture and that'd be your vaccine. And that's how most of our vaccines that we still use today, have been designed and developed, and they've been really good vaccines. But the viruses that we're trying to deal with, some of these emerging viruses, are just much trickier, and the tools that we have in the toolbox now to design vaccines are so sophisticated in terms of genetic engineering and being able to take, in the case of this coronavirus, what is typically the spike protein, and either insert it into into a structure that acts as an adjuvant and helps boost the immune system, or take the genetic code for the spike protein and deliver that in a couple of different ways. So either deliver it as what we'd call naked DNA or naked RNA, or deliver it encapsulated, or put it into a viral vector of another virus that is kind of, weak and just meant to be a transport mechanism, put it into that viral vector and use that viral vector as part of the vaccine. So that's what the chimpanzee adenovirus vaccine does. It's kind of been spliced up, part of the code for the spike protein put in there, and then that's the way to actually get to see the immune system fascinating, absolutely fascinating, and really exciting because we have never had a coronavirus vaccine. We've only had phase 1 studies for SARS and MERS. In one of those MERS phase 1 studies was just recently reported. Pretty interesting stuff in terms of safety and how immunogenic these vaccines are going to be.
Thanks. So we'll be able to get you back as we hear some more, because obviously this is the news that we are all waiting for. Because again, if we just sort of thinking about what Kerry's been saying and you've been saying in terms of this sneaky virus in our community and the knowledge that it is everywhere in the rest of the world, and we don't want it in the numbers that it is everywhere else, we're still going to have to operate as an island, even if it's an island with New Zealand eventually down the track. And it'd be interesting to sort of, think what timeframes are we thinking about? Because, I hear, Norman Swan was talking about planes being safe to travel on. It's like, well, yes, but you need to say, do we really want planes coming in from overseas? Maybe that's okay for traveling around Australia, but, are we keeping them out and for how long? Kerry, Nigel?
Look, I think that these are questions that will be continually under review. I think the vaccine and the timing of vaccine is a key factor that will potentially be a game changer or an important input into any of our decision making. I think that it's pleasing to see the progress, and I think what Christine's alluding to is the fact that you don't just need an effective vaccine, you also need the production and distribution components of the vaccine. But what's pleasing is that I understand some people are doing the science about the vaccine development at the same time as they're building the factories to manufacture the vaccine, which is sort of, again, unheard of. So the global approach to this is actually unique. But even having said that, even the most optimistic amongst us would be saying that we would not be seeing quantities of vaccine until 2021 and the second half of 2021. I don't know, Christine, if that's what you'd still be sort of thinking if you were the optimist.
Look, I think we're going to see vaccines come through the pipeline. There's going to be a need to start to put some of them into production, but I totally agree with those sort of timelines, Kerry. It's and all of the world is going to want to be vaccinated simultaneously. I mean, there's just no way that we're going to have enough at the beginning to even perhaps reach just, say, healthcare workers and what the vaccine that might be. The other thing is to think about which vaccines are coming first. Will it be the vaccine that is going to be effective and immunogenic in a healthy, 40-year-old healthcare worker in the COVID ward? But that vaccine may not be terribly effective in the 75-year-old or the 70-year-old that you'd like to immunise in the community because they're most at risk of disease. It might be that a vaccine of a different design that's got a different makeup that has a strong adjuvant that's immunogenic in the elderly is going to be needed there. So we just don't know these things yet. Until we start to see the data on what the vaccines look like, it's going to be challenging to think about who those priority populations are, and we're going to have to then think how much vaccine's coming down the pipeline, who's it best to give to, who's it targeted for. It's just going to take time, and in terms of getting the whole population vaccinated to be able to totally rely on a vaccine-induced herd protection, I think that's going to be a considerable time, to be honest. So it's part of this medium-term strategy where we're learning that we can live with the virus. How do we live with it while we're waiting to be protected, against it through a vaccine? It's going to take some time. I'm not pessimistic. I think it's going to happen, but I just think we've got to be constantly reassessing this, as Kerry indicated, and looking closely at what those timelines will be. It's not going to be like, come March next year, we'll be immunising 26 million Australians. It's not going to happen like that. I'm probably not as blunt about that with the media as I am here with general practice, but I I think it's fair to say, I hope it's a reasonable message.
I think that's a great message, and it's good to hear those details. I guess that makes me sort of wonder about, like, what are the other sort of aspects of this sort of moving towards the new phases? What are the other things we should be considering as we start to move forward? Kerry, did you have, or Nigel, did you have thoughts on that?
Look, I think part of the issue is how do we open up business and the economy in a way that really still serves to mitigate the risk of transmission. So I think that's where a lot of the attention's going at the moment. So how do we actually get crowds moving around, but moving around in COVID-safe environments? How do we keep public transport COVID-safe? We're certainly doing things like requiring a lot of businesses to keep phone numbers and contact details to support contact tracing, again, with the idea that we need to respond to clusters and outbreaks quite quickly. But hopefully you and your colleagues are seeing some of the environments around you change. We're doing some more work with shopping malls because they were never closed, and so we've identified the need to do more work with shopping malls to make them work a little harder to, be COVID safe. So I hope you see businesses behaving in ways that keep it at the forefront, that you've got to do the hand hygiene, and keep that physical distancing. So that's one aspect. The aspect is thinking about our borders, and clearly the effectiveness of the hotel quarantine has been achieved great things, but that can also be an asset. So how can we allow more people in, but knowing the science of quarantine being an effective one that we can rely on to keep us safe. And then I think trying to continue to reinforce, one of the challenges we're going to have, and we're sort of doing some work now about making testing acceptable. We're talking about what are the barriers for people coming forward for testing, given that we're wanting them to come repeated times. Is the self-isolate, at the moment we're sort of messaging that you'll go home and isolate. Is that a barrier to people getting tested? Are people getting test results in a timely way? Are people getting negative results informed in a timely way? So we also understand that given this is going to be a long journey, we're going to expect the public to just keep coming forward for testing. And so we're going to have to do a lot about how to make that acceptable to them and appealing. And that's going to be by our messaging, but I think GPs have a key role in reinforcing and almost congratulating your clients or for coming forward for testing, because I think that's a behaviour we're going to have to keep on perpetuating, and that comes with a personal cost to them, and we need to make sure there's no disincentives for that.
Kerry, I think
yes,
that's really important. Yeah, I was just going to say, I think that's really important. And I know when I'm working in the respiratory clinic in particular, we're getting a lot of people thanking us for doing the testing, and we're also thanking them back. So there is a lot of appreciation, I think, in certain parts of the community. But I do think the message that you need to, just because you've been tested once doesn't mean you don't need to be tested again, is probably needs to be encouraged. And I wonder whether also, I know some people, once they've had the testing, go, oh, that was an experience. And I wonder whether self-testing is another option that we should be promoting that maybe a little bit more.
Well, Christine might want to talk about this, but I know you trialled in the school research projects, giving people some video to watch or, some guidance, and then doing the self-test, and you did detect cases through that, and it seemed to be acceptable. So I'm really open to exploring all testing methodologies that make it seamless and straightforward for people to get a test. But Christine, did you want to comment on the self-testing experience with self-test?
Yeah, thanks, Kerry. So we've been sort of supporting New South Wales and doing two studies. One was the schools transmission study, which you might have heard about, and there's a report, referenced on both the New South Wales Health website, a paediatric report, but on our own website, there's the schools report. And as part of that, we offered extra testing to, children and teachers who'd gone home and were quarantining at home after contact with a case in the school, extra testing for the virus. And we pretty soon found out that if we had a nurse rock up to the home while they're in quarantine or ask them to go to a COVID testing centre, you know, that wasn't going down so well, doing the whole PPE and everything. So we used a video that has been used also in another study, which is called the First Few Hundred study, which is a household transmission study that, again, New South Wales have been supporting and we've been delivering on, and is being coordinated out of a site in Melbourne, the Doherty Centre. So in both of those contexts, we've dropped off the swabs at home, and we've had, you know, either the person or the parent conduct the swab using very clear instructions. And we think that that's an effective way. It's been examined quite formally with influenza as a way to do testing with influenza, but it's not really widespread that I'm aware of at the moment. I did see someone in the chat say a pathology testing centre was suggesting that's an option. I think there is a potential that, you know, someone wouldn't sample. It's quite yucky to go in so deep, isn't it, with a swab, and certainly doesn't feel good once you start to get in there for the recipient. So I think we feel it's worked well. It probably wouldn't be something, I think, we shouldn't ask the pathology collectors to give up their day job here, but it can be an option in certain settings. And I think it's going to be looked at more and more, as are, you know, other ways of testing. But you've got to have, you know, you've got to have the collection method right, and you've got to have the right test, laboratory test done on that specimen to be sure that you've got the, you know, appropriate sensitivity for that particular type of sample.
Can I weigh in at this point and agree entirely it's about the population you're wanting to test. Last night at a group meeting of GPs, we were talking about the difficulties where a lot of these GPs were in rural and fairly remote locations where the patients needed to travel considerable distances to get to a lab in order to be tested. And that's a huge disincentive, along with the fact that obviously the numbers of infections in those communities have been so low. So there was, you know, it's like, well, what incentive do you have if you're asking someone to travel 80 kilometres to go and get a test when you're figuring that the likelihood of it coming back positive is so low? Whereas if you could at least give them a kit and say, go home and test yourself, there's far more incentive for that population and cohort to actually be compliant with continuing with the testing. Otherwise, we do run the risk of losing both the GP and the patient populations in being able to feel like there's a real reason, a raison d'etre for doing this sort of thing, because it is costly both in petrol, travel time, etc. Kerry?
Look, I think you're right, and I think we're going to have to explore all sorts of methods going forward as we journey with this. I think one of the things about this response is it's going to have to be flexible and agile and evidence-based. And I think there is a bit of work from some of the pathology companies and others, and obviously the Public Health Laboratory Network, which is a committee that reports to the Australian Health Protection Principle Committee, keeps its eye on the evidence supporting different collection models. And Christine was alluding to other thoughts about other swabbing methods or other things that might also be associated with acceptable sensitivity and specificity, but be more acceptable in different clinical settings.
Penny, do you got any questions there?
Yeah, no, look, I was just going to add also, one of the things we've been doing lately, which seems to be working quite well, and this is just a little practical tip, is that we've actually been writing on the forms when we do a test is please SMS any negative result to the patient's mobile and getting consent from the patient. And that seems to be working very well, because the labs are now sending across the result as well. And so it gives you a double opportunity to get the result. And also, I rang a patient this afternoon and she said, oh, I got that SMS result this morning. I'm like, oh, great, before I even got it. So I think that also helps if people think they're getting punctual replies as well.
Yeah, no, the results have been coming through really efficiently. It's been great. Actually, can I also say that I've had I think 4 reports of children who've had testing done at the Children's Hospital who've said how easy the testing was. From the sort of parents said it was really not nearly as unpleasant as I had warned them it might be. So I thought I'd give that as a positive. It's always good as well. Nigel, I'm mindful that we haven't called on you for anything. Is there anything you would like to add into the conversation for us at this point?
Only to say that we've been doing a lot of work with our communities of practice and the primary care community of practice that you're on, Charlotte, as well, about thinking of what we need to do differently in terms of service delivery as we come out of the changes that have been put in place to respond. We rapidly moved to changing the way we deliver care and brought in a whole lot of virtual care and stopped a whole lot of services. And we're really conscious of the fact that we need to rapidly reintroduce access to care for people, particularly with chronic conditions. But we want to do that with the thoughts about what's actually worked well in our experience over the last 6 or 8 weeks, with that as a foundation for maybe doing things differently in the future. So we're very keen to get feedback from people about what they think has worked or not worked over the last little while. We're doing that through our communities of practice and really keen to get that feedback to ensure that we can factor that into our service changes in a sustainable way for the future. And I think some of the issues around telehealth item numbers and advocacy for the maintenance of those will be key. Some of the issues about the introduction of the technology that we've put in place to support hospital in the home and virtual care. We're really keen to make sure that we demonstrate the benefit of that in terms of outcomes for patient, but also outcomes and experience for the providers. So I think we're really keen to hear from people about what they feel has worked well and not worked well over that time.
Thanks, Nigel. And can I build on that? I mean, it is a real opportunity to not just fall back into doing what we did just because that's what we did it, and look at the clinics for review that can be done remotely, particularly when we think about patients for whom access to services is difficult. And that's not just a rural setting. It is, I've got a number of elderly patients for whom to be able to have a review where it is just a matter of having a conversation with the doctor and they don't need to actually go into the hospital. They might need blood tests, but they can do their blood tests locally or they can have them done at home, is really going to improve the quality of the experience for patient care without compromising quality or safety in the actual service itself. So great going forward. And I'll use this opportunity to say that look out for an announcement very shortly, but we do have an undertaking from the government that telehealth will continue to be funded in general practice going forward after September, which is fantastic news. It will be different from what it's looking like now, but for general practices that are delivering patient face-to-face care as well, it's all good news. So look out for that. We're really happy with the way the conversations have gone in that space.
So look, I would like to thank everyone tonight, and thank you again, Kerry and Nigel. You're always here, which has been, it's really good to be able to have these conversations with you. Thank you, Christine, for coming on. It's always good to have your enthusiasm and energy, and Charlotte. I think we need to hand over to Bethany now to wrap this up.
Thank you, Penny, and you've said it quite well. Thank you for your ongoing work, Kerry and Nigel, and both to Charlotte and Penny as well. You were excellent. And thank you so much, Christine, for joining us tonight. It's been an absolute pleasure having you on. Unfortunately, we are running out of time. And as always, there is quite a few questions that we haven't been able to get around to, but we do work behind the scenes to get those answers to you. So I will wrap up and say good night, and thank you all for joining. Thanks. See you later.
Thank you, everybody, and we'll see you soon for the next one. Look out for the dates for the next webinar going forward. And thank you from me as well to Nigel, Kerry, and Christine, and Penny. Farewell.
Thank you.
Good night.